One, two, one, two. Hello, everybody. Recording live from somewhere. It's Zach Couples with Movement Debrief, where we talk about whatever the hell's on my mind. And I got a couple things on my mind today that I'm hoping we can chat about. We'll talk a little bit about two topics in particular. First topic is going to be updating you guys on the girl who I saw, if you remember from episode 1, who had the lumbar fusion. So we're going to find out what I did and can do better on a few days after the first session. And then I'm going to talk a little bit about just a conversation I had with a couple friends on the state of our profession. I have heard that I look like Eric Cressy, or at least I think that. I mean, I don't know, man. It's a bald head. But anyways. Before I get into those topics, a couple housekeeping things. First thing, tomorrow I am going to put out a new blog post. It's probably going to be actually, I don't know what time. I usually try to keep them around noon Central Standard Time. So if you guys are around, man, it's going to be a big post. It's going to be something a little bit different than what I normally put out. So I hope you guys like it. I hope you guys get a lot out of it. Other housekeeping thing, as you can see, I'm in a dope hotel right now because I am on a road trip. We're going to talk more about that on Thursday. But got some new things in the works, so I look forward to keeping you guys updated on that. Without further ado, let's get on to our topic. So, if you guys weren't around for episode 1, I saw this girl. She had a lumbar fusion. Back was fine. Starting to get a little bit of shoulder pain when she was sitting for a prolonged period of time, and was just feeling kind of off. She felt like she was very right-sided dominant. And so, to update you guys on how she presented this second and third visit, I did just see her real quick before I left today. Really nice changes. For you SFMA peeps, she had about a 50% range of motion on multisegmental rotation when I first saw her, both sides. And today, I mean, she was full. So it was completely remarkable. So kudos to her. Now, part of my treatment strategy when I'm seeing someone over the course of however many visits or weeks, I try not to vary the exercises that I select too much from a week-to-week standpoint. And the reason why that is because we have to think about motor learning concepts and how long does it take for someone to learn a task well. And if you're changing up your activities, if you see someone a couple times a week and you're changing up your activities both of those times, what type of carryover are we getting from session to session? And it's really hard to say. Now, in this instance, I know that I am probably not going to see this patient for a very long time. And because she was doing so well, it was kind of worth the risk to progress her from her 2 initial activities, which were really emphasizing sagittal plane abdominal control. So we did a lot of squat variations. So when you're kind of in a middle or a conundrum of how do I make sure that this person is still learning relevant concepts from the initial session while still trying to progress her so she continues to improve. And what I found was helpful, and what I found helpful in the past, is carrying over concepts from those initial tasks into new tasks. If you think about it like a basketball player, and let's say you're trying to get better at jump shooting. Well, if I teach you how to just shoot a jump shot from, say, the paint, or the inside of the basketball court. Well, the mechanics aren't that much different when you go out into the deep mid-range. So let's apply that same concept to exercise selection. So 2 moves that were consistent with her first activities I gave her and her most recent ones were Closing the rib cage, doing the best Michael Jackson impression, getting to J-Lo, or not J-Lo, but Michael Jackson, so you get the posterior pelvic tilt and get a nice abdominal contraction. So what I did this time was keep those two pieces prevalent in her next two activities. And all I did was just shift her to one side. So instead of them being a bilateral flexion-based posture, instead of being something like this, I just had her shift over to one side and keep the same position. And then maybe we throw in a reach. So we're still emphasizing sagittal plane activity, but we're just shifting her to one side. And what that's going to do is incorporate a little bit of frontal plane, but still really emphasizing abdominals. The other activity that I chose for her was a quadruped position that just passively shifted her to her left side. And again, very same thing. It's slowly introducing frontal plane activities while still carrying concepts over from the prior exercises that we used. And when I'm cueing her in particular on these activities, I try to link back to those as much as we can, because that's a familiar concept to her. And that's ultimately what we want, is I want her to teach her basic concepts with these early visits that she's just going to put together down the line. And so, a cue that I used for her on our first session was to make sure you tuck your hips, or I used the Michael Jackson cue, and I made sure that we cue her to pull the rib cage down, back, and in. And I made sure to use that exact same verbiage with these two activities. And she ended up doing very, very well with those, in the sense that, I'm trying to think what she was presenting with symptom-wise. That's right, she was getting a little bit of like pec soreness, and just by incorporating those two activities, we were able to alleviate most of that. The rest of it, we had to use some manual interventions to clean that up. And so all I did was just a couple of rib cage mobilizations and a little bit of soft tissue to the pec, and she was golden. So point being, I think when you're coaching your clients through any type of exercise progression, you want to make sure that you keep your verbiage as consistent as possible. And it's always helpful for them to link back to prior concepts. Another strategy that I did with her that I think was very successful was kind of letting her figure it out a little bit more. I think one error I've made in the past is just overcoaching a lot of things because I want the movements to be perfect. And that's not always helpful from a learning standpoint. And so if, for example, for her, like on exercise number 1, we would do 4 sets. Well, I would teach her basically perfect technique on set 1. And then set 2, I said, okay, I just forgot what we were doing. Can you explain it to me? And so she would talk through each piece of the activity. And I found that by doing that, when I saw her the third time before I left today, she was on it. She was figuring stuff out. And then the things that she didn't figure out, or the tweaks that we made with her activities, I had her write them down in her own words, so she, again, had much better understanding. So, that's kind of been a big change for me in terms of how I've practiced over the last couple of years, whereas I think I was a big-time overcoacher early in my career, and I could even say a year ago, and I've slowly begun to shift away from that. And who knows, that may change 6 months from now. I certainly hope something of what I do changes 6 months from now. So that's pretty much my case for today. The second thing I wanted to talk about was just what our profession, because I'm a physical therapist, prioritizes. And this discussion was kind of inspired by a dinner I had with my good friends Eric Otter and Lex Potter, who I will miss dearly. And I'm thinking about this time I was on Facebook, and there's a lovely physical therapy group on Facebook, which I won't name, but there was a discussion about dry needling. And I'm not going to tell you what my stance is on dry needling, because it's irrelevant to the story. But these conversations always go under the same framework. Person asks, would a dry needling course be helpful for patient X? And you have 3 people say, I took this course and this was helpful, or I used it with similar patients and this was helpful. And then all of a sudden, the 4th post is always someone who just either carpet bombs 10 research studies, or they just say that's bogus and nothing else, and basically just cut down that conversation. And we can get into talking about how to actually interact like a human being on the internet, but I look at posts like that, and I think to myself, in terms of how much we beat each other up in our profession, when we still don't have complete direct access in all 50 states. Where are our priorities when we're trying to tell like-minded clinicians who are just trying to help their people and it could be ways that are completely bogus and that I might think are completely bogus. But yet, as a profession as a whole, we don't have the capability to maximally helping our people as is. And you want to battle about things that really aren't relevant and, in some cases may limit certain practitioners, when as practitioners already we are limited. I mean, what's more important? Making sure that all of our manual interventions are at the utmost evidence base, or whether or not we create a nocebo response from maybe educating someone on needling in a certain way, or being able to access the most patients we can by having direct access in 50 states. And I don't know what the right answer is for that. I tend to think it's going to be getting direct access, because that way we at least have the capability of helping more people. And I also think instead of trying to further limit our treatment paradigms, we need to expand those things. And I'm not even talking about, whether or not dry needling or, instrument-assisted soft tissue mobilization or some other controversial thing that we do is effective or not. I'm not even talking about that. I'm talking about getting us involved in things that maybe military PTs could do, like order imaging. I mean, if we're trying to be the practitioner of the future, and especially with Vision 2020, and we want to be a primary care person, this is something we need. We also probably need to get into a position where we can give nutritional advice or order blood work or do some of these tests so we can better stratify where patients need to go or who they need to see. And that's just something that when we fight over these petty things that really don't matter for right now, we spend so much time doing that, and it's at the expense of advancing us as a profession and our scope. And ultimately, I think that's what we need to do in order to help the most people and maximize our capabilities. So that's going to be my soapbox for today. I think we'll call that it for tonight. Again, ZachCouples.com. I got a post coming out tomorrow. It's going to be huge. Go check it out. You can also follow me on Facebook if you're not on Facebook. Or you can follow me on Twitter. My handle is ZCouples. Or you can follow me on Instagram, Zach Couples. I'm also on YouTube. Just look up Zach Couples. And it's been great. I enjoyed this. I'm hoping we'll put out another one sometime on Thursday. I'm going to shoot for these to try to be around 8 p.m. Central Time. So I don't know. If that changes, I'll keep you guys posted. But until next time, take care.